Cardiac afterload is one of the main factors that influence how much blood the heart pumps out with each heartbeat or stroke. Now remember that the heart has two upper chambers. The left atrium, which receives oxygenated blood from the lungs via the pulmonary veins, and the right atrium, which receives deoxygenated blood from all of our organs and tissues via the superior and inferior vena cava. From the atria, the blood flows into the lower chambers of the heart, the left ventricle, which pumps oxygenated blood to all our organs and tissues via the aorta, and the right ventricle, which pumps the deoxygenated blood back to the lungs via the pulmonary arteries. Alright, now each heartbeat consists of two phases. Systole, which is when the heart contracts and pumps the blood out of the ventricles, and diastole, which is when the heart relaxes and ventricles fill with blood. And as the left ventricle fills with blood during diastole, the pressure within it rises. Then, the left ventricle contracts, increasing the pressure within the left ventricle even more and forcing blood through the aortic valve into the aorta and whole arterial system. So cardiac afterload can be defined as the ventricular wall stress during systole or ejection. And it can be calculated using the law of Laplace, which states that wall stress equals pressure P times radius R over 2 times wall thickness W. Another way to say this is that cardiac afterload is directly proportional to the pressure inside the left ventricle during ejection, as well as the radius of the left ventricle, and indirectly proportional to 2 times the ventricular wall thickness. To visualize this, let's look at a cross-section of the left ventricle, which looks a bit like a donut with little dough, a diet donut if you will. Now the little dough circle represents the wall of the left ventricle, and its thickness is the ventricular wall thickness, or W. Pressure, or P, on the other hand, refers to the pressure exerted by the ventricular wall on the ventricular cavity during systole. And finally, the radius is the distance from the center of the ventricle to the outer edge. So actually, the radius, or R, comprises of an inner radius, or RIN, which is the radius of the ventricular cavity. And the full radius is RIN plus the ventricular wall thickness. And if you thought we were done with math, hold your horses. There's one more formula we need to calculate, the inner radius, which is RIN equals the cube root of 3 times V over 4 times pi, where V is the volume of the left ventricle, or RIN equals 3 times V over 4 times pi to the power of 1 over 3. And then we can add wall thickness to the inner radius to determine the left ventricular end diastolic radius, or R. Now it's important to note that this formula isn't used in clinical practice. Instead, clinicians simplify the equation by eliminating 2 variables, radius and wall thickness. So for simplicity's sake, we can say that left ventricular wall stress during ejection is proportional to left ventricular pressure during ejection. And if we assume that left ventricular pressure during ejection is equal to aortic pressure during ejection, then we can say that left ventricular pressure during ejection is equal to what we commonly know as systolic blood pressure. This leads us to a most commonly used definition of afterload, which says that afterload is the amount of resistance that the ventricles must overcome during systole. So left ventricular afterload is affected by systemic vascular resistance, as well as aortic pressure and valve diseases. Systemic vascular resistance is the resistance of systemic blood vessels to blood flow. In other words, how readily blood vessels allow blood to flow through them. Now, systemic vascular resistance is mainly affected by changes in the vessel lumen, which is determined by vasodilating and vasoconstricting factors. Vasodilating factors such as atrial natriuretic peptide, or ANP, which is secreted by cardiac muscle cells in the walls of the atria in response to an increased blood volume, relax smooth muscle cells within the vessel walls, thereby widening the vessel lumen. This results in decreased systemic vascular resistance and therefore decreased afterload. On the other hand, Vasoconstricting factors, such as sympathetic stimulation, constrict smooth muscle cells within the vessel walls, thereby narrowing the vessel lumen. Eventually, this leads to an increase in systemic vascular resistance and therefore increased afterload. Next one is aortic pressure. Increased aortic pressure means that the heart must contract harder and generate more pressure within the left ventricle in order to overcome aortic pressure and open the aortic valve. Therefore, increased aortic pressure increases afterload, while decreased aortic pressure reduces afterload. And finally, let's look at valve diseases. First, let's start with the aortic valve, which is between the left ventricle and the aorta. If the aortic valve doesn't open all the way, which is called aortic stenosis, the heart must generate more pressure in order to eject blood during systole. This increases the stress on the left ventricular wall, therefore increasing afterload. On the flip side, there's mitral regurgitation, which is when the mitral valve, which is between the left atrium and the left ventricle, doesn't close all the way. So during ejection, blood leaks back into the left atrium. This decreases the stress on the left ventricular wall, therefore decreasing afterload. Alright, as a quick recap, afterload is defined as the left ventricular wall stress during systole or ejection. Through the law of Laplace, we can say that afterload is directly proportional to the left ventricular pressure during ejection and radius during ejection, and indirectly proportional to 2 times the left ventricular wall thickness. But for simplicity's sake, we say that the left ventricular wall stress during ejection is proportional to left ventricular pressure during ejection. And if we assume that left ventricular pressure during ejection is equal to aortic pressure during ejection, then we can say that left ventricular pressure during ejection is equal to what we commonly know as systolic blood pressure. Finally, factors that affect left ventricular afterload include systemic vascular resistance, aortic pressure, and valve diseases such as aortic stenosis and mitral regurgitation.
The main job of the heart is to pump blood all over the body to our organs and tissues and keep them oxygenated. It does so by contracting around 70 times per minute. The physiological basis of cardiac contractility is the synchronous contraction of heart muscle cells, aka cardiomyocytes. Cardiac contractility is a measure of the strength of cardiomyocytes to contract. In order for cardiomyocytes to contract, they first need to depolarize. Depolarization is when ions move across the membrane of a cell and the membrane potential becomes less negative or even slightly positive. Think of a really pessimistic negative cell throwing his hands up and enjoying a moment of joy. When one cell depolarizes enough, it can cause some ions, like calcium, to flow into neighboring cells and trigger them to depolarize as well. If one cell after another depolarizes, then there's a depolarization wave, which you can imagine would look like a wave moving through a crowd at a football stadium. Each depolarization wave causes a heart muscle contraction, so the rate at which depolarization waves ripple through the heart actually sets the heart rate. This depolarization wave starts with the sinoatrial node, which sometimes gets called the SA node, and then moves through the rest of the heart to cause a contraction. So if depolarization waves are going through about once per second, that means that your heart beats once per second, or 60 times in a minute. Now, let's zoom in on a cardiomyocyte. These hardworking cells have branches and intercalated discs along their edges, which have small holes called gap junctions that allow ions to flow from one cardiomyocyte to the next. When ions like calcium move from that cell into a neighboring cell, this triggers depolarization, and cardiomyocytes depolarize one after the other. Another feature of cardiomyocytes are passageways called transverse tubules, or T-tubules. T-tubules are invaginations, or tunnels of the cardiomyocyte membrane, that increase the surface area of the cardiomyocyte, and they look like the letter T, so it's easy to remember their name. One last important element to depolarization and contraction is the sarcoplasmic reticulum, which is an organelle that stores the intracellular calcium. When a depolarization wavefront hits a cardiomyocyte, a few calcium ions flow through gap junctions. Looking at the cell membrane, if a threshold membrane potential is reached, then sodium channels start to open up. If there's a depolarization, then calcium and sodium ions start to move across the cell membrane and into the cell. That's where the T-tubules play a key role by bringing calcium deep into the cell. Once this extracellular calcium gets inside, it binds to the ryanodine receptors on the sarcoplasmic reticulum, which releases even more calcium into the cell, a process called calcium-induced calcium release. This process helps to activate two contractile proteins, actin and myosin, which are called myofilaments. Myosin is able to attach and pull actin with the help of adenosine triphosphate, or ATP, to form cross bridges that result in shortening of the muscle fiber. Eventually, calcium ions are removed by ion transporters that rely on ATP or concentration gradients. Now that we understand how a cardiomyocyte contracts, we can look at the various factors that affect cardiomyocyte contractility. Contractility is directly related to the concentration of calcium within the cardiomyocyte, so any factors that increase intracellular calcium levels will increase cardiac contractility. Since calcium is stored in the sarcoplasmic reticulum, concentrations of calcium will vary with how much calcium there is intracellularly and how much calcium is stored within the sarcoplasmic reticulum that is available to be released. One of the main methods intracellular calcium can be changed is with the autonomic nervous system. The heart is innervated by both parasympathetic and sympathetic neurons of the autonomic nervous system. Sympathetic neurons have a positive inotropic effect, where positive means increase and inotropic refers to contractility. So sympathetic stimulation increases cardiac contractility by releasing catecholamines like norepinephrine, which bind to beta-1 receptors on cardiomyocytes. Activation of the beta-1 receptors leads to downstream phosphorylation of proteins like sarcolemmal calcium channels on the sarcoplasmic reticulum membrane, which increases the sarcoplasmic reticulum's ability to release calcium. Phosphorylation of phospholambin, a protein found on the sarcoplasmic reticulum membrane, regulates calcium ATPase, a calcium pump which transports calcium from the cytoplasm into the sarcoplasmic reticulum. When phosphorylated, these calcium pumps become activated, which increases the amount of calcium brought back into the sarcoplasmic reticulum, resulting in greater uptake and storage. This increases calcium stores for subsequent depolarizations. Finally, phosphorylation of plasma membrane L-type calcium channels will increase their permeability to calcium, allowing increased amounts of extracellular calcium entry into the cardiomyocyte. On the other hand, parasympathetic stimulation has a negative inotropic effect, so it decreases contractility, mainly due to acetylcholine activating muscarinic M2 receptors on cardiomyocytes. This leads to a downstream cascade of intracellular events that ends with inhibition of calcium channels. With less working calcium channels, there is less calcium moving into the cell and less calcium released from the sarcoplasmic reticulum, leading to decreased contractility. In addition, parasympathetic stimulation also acts on the sinoatrial node, decreasing heart rate. Heart rate itself can also independently change contractility. For example, with a higher heart rate, there are more action potentials per unit of time, and each action potential's inward calcium influx results in an increase in the total calcium that enters the cell. With greater amounts of calcium entering the cell, the sarcoplasmic reticulum also accumulates more calcium for subsequent action potentials. Additionally, if the increase in heart rate is due to sympathetic stimulation, phosphorylation of phospholambin and sarcolemmal calcium channels increases release, uptake, and storage of calcium within the sarcoplasmic reticulum. This can be seen graphically as the positive staircase effect, where an increase in heart rate is shown to increase inotropy gradually at first as calcium is not yet accumulated, but with each successive beat, more calcium is available for the sarcoplasmic reticulum with a corresponding increase in inotropy until finally a maximum storage level is reached and maximum inotropy is seen. This effect can also be seen in post-extrasystolic potentiation phenomenon. Post-extrasystolic means following an additional premature heartbeat, so a heartbeat that is not commanded by the sinoatrial node for whatever reason. This premature beat has a less than normal strength of contraction, as the ryanodine receptors on the sarcoplasmic reticulum have a transient refractory period at this point, causing a transient decrease in calcium within the cardiomyocyte. After this premature beat, sarcoplasmic calcium load is increased, as this premature beat did not allow the sarcoplasmic reticulum to release calcium from the last two beats, and all of the calcium that's built up gets released together, resulting in an increased contraction. Sometimes that increased forceful contraction can be felt by those who are experiencing an extrasystolic beat. Another way intracellular calcium can be increased is with a class of drugs called glycosides. They are extracted from the foxglove plant Digitalis purpurea. The most commonly used glycoside is digoxin, and it works by inhibiting the sodium-potassium ATPase located in the cell membrane of the cardiomyocyte by binding to the extracellular potassium binding site. Normally, the sodium-potassium ATPase will pump out 3 sodiums for every 2 potassiums that it pumps in, with the help of 1 ATP. When sodium-potassium ATPase is inhibited, less sodium is pumped out of the cell, which builds up the intracellular sodium concentration and decreases the sodium gradient across the cell membrane. This decrease in the sodium gradient affects the function of the calcium-sodium exchanger, which normally pumps 1 calcium out of the cell against its electrochemical gradient by using the energy from a sodium moving into the cell down its electrochemical gradient. Since less sodium is pumped out by the sodium-potassium ATPase, less calcium is able to be pumped out by the calcium-sodium exchanger. As a result, the intracellular calcium increases and inotropy increases. The main use of this class of drugs is for patients with congestive heart failure whose ventricles can't contract hard enough to pump enough blood into the body. So, this class of drug is used to stimulate contractility. Alright, as a quick recap, cardiomyocyte contractility depends on intracellular calcium concentration. This concentration can be modified by autonomic nervous system input, where sympathetic activation increases contractility and parasympathetic activation decreases contractility. Contractility can also be increased independently by an increase in the heart rate. And finally, a class of drugs called glycosides, like digoxin, can be used by patients who need some extra help with contractility, like those with heart failure.
Cardiac preload is one of the main factors that influence how much blood the heart pumps out with each heartbeat or stroke. Now remember that the heart has 2 upper chambers. The left atrium, which receives oxygenated blood from the lungs via the pulmonary veins, and the right atrium, which receives deoxygenated blood from all of our organs and tissues via the superior and inferior vena cava. From the atria, the blood flows into the lower chambers of the heart. The left ventricle, which pumps oxygenated blood to all our organs and tissues via the aorta, and the right ventricle, which pumps the deoxygenated blood back to the lungs via the pulmonary arteries. Alright, now each heartbeat consists of 2 phases. Systole, which is when the heart contracts and pumps the blood out of the ventricles, and diastole, which is when the heart relaxes and ventricles fill with blood. And as the left ventricle fills with blood during diastole, the pressure within it rises. The pressure at the end of diastole is called the left ventricular end diastolic pressure, which is a key determinant of cardiac preload. So cardiac preload can be defined as the ventricular wall stress at the end of diastole. And it can be calculated using the law of Laplace, which states that wall stress equals pressure P times radius R over 2 times wall thickness W. Another way to say this is that cardiac preload is directly proportional to the end diastolic pressure and radius of the left ventricle, and indirectly proportional to 2 times the ventricular wall thickness. To visualize this, let's look at a cross-section of the left ventricle, which looks a bit like a donut, with little dough. A diet donut, if you will. Now the little dough circle represents the wall of the left ventricle, and its thickness is the ventricular wall thickness, or W. Pressure, or P, on the other hand, is determined by the volume of blood inside the ventricle at the end of diastole. And finally, the radius is the distance from the center of the ventricle to the outer edge. So actually, the radius, or R, comprises of an inner radius, or RIN, which is the radius of the ventricular cavity, and the full radius is RIN plus the ventricular wall thickness. And if you thought we were done with math, hold your horses. There's one more formula we need to calculate. The inner radius, which is RIN equals the cube root of 3 times V over 4 times pi, where V is the volume of the left ventricle at the end of diastole. Or RIN equals 3 times V over 4 times pi to the power of 1 over 3. And then we can add wall thickness to the inner radius to determine the left ventricular end diastolic radius, or R. Alternatively, preload can be defined as the length of muscle fibers, or sarcomeres, at the end of diastole. So let's zoom in on the wall of the left ventricle. The bulk of these walls is made up of short, branched cardiac muscle cells packed one next to the other. Zooming in further, if we look inside the muscle cells, we see bundles of myofibrils, or long chains of sarcomeres. The sarcomere is the smallest structure in the muscle that is capable of contracting, so it's considered the basic contractile unit of the muscle. Zooming in further, you can see that the sarcomere has 2 Z discs that form its boundary, and an M line in the middle. Attached to the Z disc are thin filaments made of actin protein. These actin filaments have structural polarity, which means the end of the filament look different from one another. We can think of it like an arrow, with the pointed end being the minus end, pointing towards the M line, and the tail end being the plus end, attached to the Z disc. Just like an arrow, the actin filament can only move in one direction, the direction it's pointed at. Attached to the M line are the myosin filaments, which are thick bundles of myosin proteins with 2 globular heads. During a muscle contraction, the myosin heads grab onto the actin filaments and pull them towards the M line, which brings the 2 Z discs closer together. So the length of the sarcomere is important because the force of contraction during systole depends on the number of myosin heads that bind to actin. This number directly depends on the length of the overlapping section between actin and myosin filaments. And the length of the overlapping section depends on the overall length of the sarcomere. But no matter how we choose to define cardiac preload, the problem is that these measurements are not possible in practice. Imagine trying to measure the length of sarcomeres in vivo. Therefore, in clinical practice, a surrogate for cardiac preload is used. Specifically, the volume of blood within the left ventricle at the end of diastole that stretches out the overall muscle wall and each sarcomere within it. It's important to note that the end diastolic left ventricular volume is not the same as cardiac preload, but it can be measured with an echocardiogram, so it's easier to use this parameter in practice. Now, the left ventricular end diastolic volume, and therefore preload, is affected by 5 factors: venous pressure and rate of venous return, atrial contraction, resistance from valves, ventricular compliance, and heart rate. First, let's focus on venous pressure and the rate of venous return. Venous pressure and the rate of venous return are influenced by 2 other factors: venous tone and circulating blood volume. Now, venous tone is determined by vasodilating and vasoconstricting factors. Vasodilating factors relax smooth muscle cells within the vein walls. thereby decreasing the vascular tone of the vein. One such vasodilating factor is atrial natriuretic peptide, or ANP, which is secreted by cardiac muscle cells in the walls of the atria in response to an increased circulating blood volume that makes an increased amount of blood reach and distend the atrium. When ANP is secreted and venous tone decreases, that results in peripheral pooling of the blood and decreased return of the venous blood to the heart. Moreover, the decreased return of the venous blood leads to decreased left ventricular pressure and decreased end diastolic volume, and therefore decreased cardiac preload. Another way to visualize this is through pressure-volume loops, which are graphs that show the pressure inside the left ventricle on the y-axis and the volume of blood inside the left ventricle on the x-axis. And the green dotted loop represents the variation over the course of one cardiac cycle under normal circumstances. When vasodilating factors are secreted and cardiac preload is decreased, left ventricular pressure and end diastolic left ventricular volume both decrease. So the loop shifts to the left. On the other hand, vasoconstricting factors, such as sympathetic stimulation during the fight or flight response, constrict smooth muscle cells within the vessel walls, thereby increasing the vascular tone of the veins. This results in an increased venous return to the heart. Eventually, this leads to an increased end diastolic volume and therefore increased cardiac preload, which helps send more oxygenated blood to organs and tissues. This might come in handy if a pack of kangaroos started chasing you at the mall. And if we look back at our pressure-volume loops, increased left ventricular pressure and end diastolic volume, and the resulting increased cardiac preload, shifts the loop to the right. Speaking of which, the amount of circulating blood volume also influences venous pressure and venous return rate. Now, an average adult has a circulating blood volume of 5 liters. But in different conditions, this volume of blood can change. On the one hand, circulating blood volume can decrease in the context of dehydration or blood loss following an injury, and this is called hypovolemia or volume depletion. Hypovolemia leads to decreased end diastolic volume and therefore decreased preload. On the other hand, circulating blood volume can increase, which is called hypervolemia or fluid overload. One cause of this is when too much intravenous fluids are given to an individual, also known as transfusion overload. Eventually, more fluids in the circulatory system will result in an increased end diastolic volume and therefore increased preload. Next factor is atrial contraction. Increased force of atrial contraction, either by sympathetic stimulation of the heart or increased filling of the atria, increases the volume of blood that enters the ventricle, eventually causing an increase in end diastolic volume, or EDV, and preload. On the other hand, when the atria can't pump blood efficiently and in sync, which is common in atrial arrhythmias, the volume of blood that enters the ventricle will decrease, eventually causing a decrease in end diastolic volume and preload. Okay, next up there's resistance from valves. This refers to the inflow valves that connect the atria and the ventricles, such as the mitral valve on the left and the tricuspid valve on the right, and the outflow valves which connect the left and right ventricle to the aorta and the pulmonary artery, respectively. Inflow resistance is created by the narrowing of atrioventricular valve openings such as mitral stenosis and tricuspid stenosis. This results in decreased filling of the ventricles and therefore decreased preload. On the other hand, outflow resistance is created by the narrowing of aortic and pulmonic valves such as aortic stenosis and pulmonary stenosis. Eventually, this results in decreased emptying of the ventricles and therefore increased preload. Next factor is ventricular compliance. which is, simply said, the flexibility of the ventricles. Compliant, stretchy ventricles, such as seen in dilated cardiomyopathy, increase preload, while non-compliant stiff ventricles, such as seen in ventricular hypertrophy, decrease preload. And finally, there's heart rate. Normal heart rate, 60 to 100 beats per minute, allows adequate time for ventricles to fill, while abnormal heart rates, such as fast heart rhythm or tachycardia, reduce the filling time, eventually decreasing preload. Alright, as a quick recap, preload is defined as the ventricular wall stress at the end of diastole. Through the law of Laplace, we can say that wall stress is directly proportional to the ventricular end diastolic pressure and radius, and indirectly proportional to 2 times the ventricular wall thickness. Alternatively, preload can be defined as the length of muscle fibers or sarcomeres at the end of diastole. But since these definitions are more theoretical, in clinical practice, the end diastolic volume is used to assess cardiac preload. Finally, the end diastolic volume, and therefore preload, is affected by 5 factors: venous pressure and rate of venous return, atrial contraction, resistance from valves, ventricular compliance, and heart rate.
More than a century ago, 2 physiologists, Otto Frank and Ernest Starling, discovered that as the heart gets filled up with more blood during diastole, it contracts harder and pumps out more blood during systole. Naturally, they came up with the Frank-Starling law to explain this relationship. To understand the relationship, let's zoom into the walls of the ventricles. The bulk of these walls is made up of short, branched cardiac muscle cells packed one next to the other. Zooming in further, if we look inside the muscle cells, we see bundles of myofibrils, or long chains of sarcomeres. The sarcomere is the smallest structure in the muscle that's capable of contracting, so it's considered the basic contractile unit of the muscle. The sarcomere has 2 Z discs that form its boundary, and an M line in the middle. Attached to the Z disc are thin filaments made of actin protein. These actin filaments have structural polarity, which means both ends of the filament look different. We can think of it like an arrow, with the pointed end being the minus end, pointing towards the M line, and the tail end being the plus end, attached to the Z disc. Just like an arrow, the actin filament can only move in one direction, the direction it's pointed at. Attached to the M line are the myosin filaments, which are thick bundles of myosin proteins with 2 globular heads. During a muscle contraction, the myosin heads grab onto the actin filaments and pull them towards the M line, which brings the 2 Z discs closer together. Overall, the amount of tension developed, or the force of muscle contraction during systole, depends on the number of myosin heads that bind to actin. And this number directly depends on the length of the overlapping section between actin and myosin filaments. The length of the overlapping section depends on the overall length of the sarcomere. And the length of the sarcomere depends on how much blood fills the ventricle during diastole, because that affects how stretched out the overall muscle wall and each sarcomere within it end up being. This relationship is known as the cardiac length-tension relationship, and it can be shown by this graph, with the sarcomere length or the ventricular end diastolic volume on the x-axis, and the tension or pressure developed within the ventricle during their contraction or systole on the y-axis. So let's imagine that the ventricles are mostly empty, with almost no blood in them. This will mean that there's nothing stretching the muscles in the ventricular wall, so the length of the sarcomeres are really short. At this length, the 2 Z discs are pulled close to each other and there's not much room for further contraction. Furthermore, the actin filaments from each side of the sarcomere cross the M line and overlap. Since actin can be pulled only in one direction, towards the midline, myosin has to attach and pull the actin filament with the right structural polarity, the one pointing in the same direction as the myosin pulls. So when the actin filaments overlap, myosin is prevented from binding to its own actin filament by the actin filament from the other side with the wrong polarity. As a result, very few myosin-actin attachments are made, and the cells can contract only very weakly during systole. On the graph, we can see near the point of origin, the short length of myocardial fibers corresponds with a low contractile force. As the ventricles fill with more blood returning through the veins, their walls get more and more stretched, and that stretches out every single sarcomere in the muscle cells as well. This means that there's more space, and no actin overlapping, which allows more myosin heads to properly interact with actin, and as a result create more force or tension during contraction. Looking at the graph, this would make our curve move steadily upwards with increasing force as there's increasing volume. This stretching can go until it exceeds a maximal point, after which things start getting too stretched out. This means the Z discs are so far apart from each other that there's only little overlap between actin and myosin filaments, and actin gets out of reach from the myosin. As a result, there's a decreased number of myosin heads that manage to attach to actin and pull it towards the M line. This leads to a decreased force of contraction, so the curve starts falling off again. Now that we've seen the relationship between length of the sarcomeres and tension during contraction and systole, let's look at the Frank-Starling relationship. This can also be plotted onto a similar graph, with the ventricular end diastolic volume on the x-axis, and the stroke volume, which is the volume of blood pumped out by the ventricle with each heartbeat, on the y-axis. So at the start of the curve, near the bottom left-hand corner, we have a low end diastolic volume, meaning very little blood in the ventricle at the end of diastole. So sarcomeres are squeezed together with very few myosin heads binding to actin. This results in a weak contraction during systole and a low stroke volume. As the volume of blood returning to the ventricles increases, sarcomeres stretch, and there's more myosin-actin binding, so a greater strength of contraction is achieved and stroke volume rises. That's true until the end diastolic volume becomes too high, and the myosin and actin get too far apart, which causes the amount of myosin and actin binding to decrease, which results in a weaker contraction, so the stroke volume falls off again. Keep in mind, though, that this curve reflects the heart's intrinsic ability to vary the strength of contraction based on the volume of blood that it's filled with. Within the body, there are plenty of extrinsic signals as well, like nerve or hormonal stimuli and medications. Some of these signals, like stimulation from the sympathetic nervous system or the medication digoxin, can have a positive inotropic effect on the heart. This means that at a given end diastolic volume, they increase the strength of contraction, moving the curve upwards and increasing the stroke volume. On the other hand, there are negative inotropic agents, like medications, like beta blockers, that decrease the strength of contraction, moving the curve downwards and decreasing stroke volume. Alright, as a quick recap, the Frank-Starling relationship between end diastolic volume, contraction strength, and stroke volume states that the strength of ventricular contraction and the volume of blood ejected by the ventricle depends on the blood volume present in the ventricle at the end of diastole.
The law of Laplace, named in honor of French scholar Pierre-Simon Laplace, is a law in physics that states that the tension in the walls of a hollow sphere or cylinder is dependent on the pressure of its contents and its radius. The concept was then later applied to medicine, since there are many hollow spherical and cylindrical shaped organs in our bodies that deal with pressures. Important examples include the blood vessels and the chambers of the heart. Okay, so according to the law of Laplace, wall tension is proportional to pressure P times radius R. Now let's break it down. The wall tension is the force in the container's walls that resists the force trying to expand it. So if we're blowing up a balloon, we can think of the wall tension as the force created by the elastic rubber wall that resists the outward force applied by the pressure inside the balloon. Now, if we break the wall tension into components, we have a vertical vector of force that's counteracting the expansion of the balloon, and a horizontal vector of force that's stretching and tearing the balloon's wall. So for pressure, if we were to blow more air into a balloon, we would expect the pressure inside to build up, and the wall tension of the balloon would increase as the walls push back against the expansion. If the pressure trying to expand the balloon is greater than the wall tension, the balloon will expand, or pop. Now another factor is the radius. A smaller radius means more pressure is needed to overcome the wall tension in order for the container to expand. This is why it's harder to blow up a small, deflated balloon than it is to blow up a half-inflated balloon. An example of this can be seen in the alveoli in the lungs of a newborn. Let's plug in some easy imaginary numbers and forego units to make this concept easier to understand. Normally, an unused alveolus in a newborn is collapsed. So let's say it has a radius of 2 and the wall tension is 8. The baby starts crying and inhales. The pressure of the inhaled air in the alveolus is 4. So our equation is 4 times 2, which gives us 8. And since this is the same as the wall pressure, the alveolus doesn't expand. In other words, the baby will need to breathe in enough air to generate greater than 4 units of pressure to inflate it. Now let's say that the alveolus has expanded after the baby took a few breaths, and the radius is now 4, and the wall tension remains the same. So this time, the baby only needs to breathe in enough air to generate greater than 2 units of pressure to expand the alveolus. So it takes a lot less work. Now a concept related to wall tension is wall stress, which uses a modified version of Laplace's law that factors in the thickness of the wall. The equation for wall stress is pressure times radius over 2 times the wall thickness. Based on this equation, wall stress is wall tension divided by 2 times the wall thickness. So the thicker the wall, the less wall stress. To see a real-life example, let's look at the heart, more specifically the chamber of the left ventricle, which resembles a sturdy, round cup. Let's say we have a person with aortic stenosis, which means the aortic valve is narrowed and it makes it harder for blood to flow through. In order to overcome this, the heart will pump harder, causing an increase in the pressure inside the heart. And as a result, we increase the wall tension. Now, in order to push more blood out, the left ventricle hypertrophies, meaning the cardiac cells grow thicker by adding more sarcomeres, the contractile units of cardiac cells. As a result, there's an increase in the wall thickness and a decrease in the radius of the chamber, and according to our equation, both will reduce wall stress. Thanks to this, the heart is less likely to tear open when under pressure. Alright, as a quick recap, the law of Laplace is a law in physics that states that the wall tension of a hollow sphere or cylinder is proportional to both the pressure of its contents and its radius. Wall stress is the wall tension divided by 2 times the wall thickness. Now, when applied to hollow spherical objects like the left ventricle of the heart, the following formula is used. Wall stress equals P times R over 2W, where P is pressure, R is total radius, and W is wall thickness. In short, the law of Laplace states that wall tension is directly proportional to pressure and radius, and wall stress is proportional to the wall tension but inversely proportional to 2 times the wall thickness.
Cardiac output is defined as the volume of blood ejected by the left ventricle per unit time. The volume of blood is called the stroke volume, and the unit used to measure cardiac output is 1 minute. So, cardiac output can be calculated as stroke volume, which is the volume of blood pumped out of the left ventricle per beat, times the number of heartbeats per minute, which is around 70. Another way to calculate cardiac output is by using the Fick principle, which simply states the oxygen going into an organ minus the oxygen left out of an organ must equal how much oxygen that organ has used. Using the Fick principle equation of cardiac output equals oxygen consumption divided by arteriovenous oxygen difference, cardiac output can be calculated. Both methods render normal cardiac output to around 5 liters per minute on average. To measure cardiac output, we first have to take a look at the left ventricle. There's a moment when the left ventricle is fully relaxed. It occurs at the end of filling or diastole, also called the end diastolic point, and the volume of blood within the left ventricle is called the end diastolic volume, and it's about 120 milliliters. Then the left ventricle contracts, forcing blood through the aorta and into the whole arterial system. After that is another moment when the left ventricle is fully contracted. It occurs at the end of contraction or systole, also called the end systolic point, and the volume of blood within the left ventricle is called end systolic volume, and it's about 50 milliliters. So end diastolic volume minus end systolic volume gives us the stroke volume, which is the volume of blood that the left ventricle ejects with every heartbeat, or stroke. In this case, the stroke volume is 120 minus 50, which equals 70 milliliters. Every minute, though, our heart beats about 70 times, on average. So, if we multiply the stroke volume times the heart rate, or times our heart beats per minute, we'll get the cardiac output, which is the total volume of blood that the left ventricle ejects in 1 minute. Using the stroke volume of 70 milliliters per beat and a resting heart rate of 70 beats per minute, cardiac output is 4,900 milliliters a minute, or 4.9 liters per minute. Remember that a normal adult body contains approximately 5 liters of blood. So this means that every last drop of blood travels through the left ventricle at least once every minute. Another way to measure cardiac output, which does not involve using the stroke volume or heart rate, is called the Fick principle. The Fick principle simply states that at rest, the oxygen going into an organ minus the oxygen left out of an organ must equal how much oxygen that organ has used. Using the Fick principle equation of cardiac output equals oxygen consumption divided by arterial-venous oxygen difference, cardiac output can be calculated. By convention, the organ used for calculation is actually the body. So the Fick principle states that at rest, the oxygen in the pulmonary veins going to the body, full of oxygen, minus the oxygen left in the pulmonary arteries coming back from the body, or oxygen left after the body has used some, must equal how much oxygen the body has used. The Fick principle also makes the assumption that at rest, the cardiac output for the right and left ventricles are the same. Each of the parameters of the Fick principle can be measured. The oxygen content of the pulmonary venous blood can be measured by taking a sample from peripheral arterial blood, since none of the oxygen added by the lungs have been consumed at this stage. The oxygen content of the pulmonary arterial blood can be measured by taking a sample of mixed venous blood from the pulmonary artery or the right ventricle. The amount of oxygen in the pulmonary veins is equal to the pulmonary blood flow multiplied by the oxygen content of the pulmonary venous blood. Similarly, the amount of oxygen returned to the lungs via the pulmonary artery is pulmonary blood flow multiplied by the oxygen content of pulmonary arterial blood. Remember that pulmonary blood flow is the cardiac output of the right ventricle and is assumed to be equal to the cardiac output of the left ventricle. Expressing oxygen consumption mathematically, we get oxygen consumption of the body equals cardiac output multiplied by the concentration of oxygen in the pulmonary vein, minus cardiac output multiplied by the concentration of oxygen in the pulmonary artery. Solving for cardiac output, you get cardiac output equals oxygen consumption of the body divided by the oxygen concentration of the pulmonary vein, minus the oxygen concentration of the pulmonary artery. For an average 70 kilogram person, total body oxygen consumption is around 250 milliliters a minute at rest. Let's work through the problem together and calculate the cardiac output for a man lying in bed. This person has an oxygen consumption of 250 milliliters per minute, a femoral arterial oxygen content of 0.3 milliliters, and a pulmonary arterial oxygen content of 0.25 milliliters. What is his cardiac output? So remember, cardiac output equals oxygen consumption of the body divided by the oxygen concentration of the pulmonary vein minus the oxygen concentration of the pulmonary artery. So, plugging in numbers, we get cardiac output equals 250 milliliters per minute divided by 0.3 milliliters minus 0.25 milliliters equals 5,000 milliliters per minute, which equals 5 liters per minute. The Fick principle is not only good for calculating cardiac output, it can also calculate blood flow for individual organs. For example, renal blood flow can be calculated by dividing oxygen consumption of the kidneys by the difference in oxygen content of the renal arterial blood and renal venous blood. Alright, as a quick recap, cardiac output can be measured either as the stroke volume times heart rate or with the Fick principle. The Fick principle assumes two things while in the steady state. First, that oxygen in the pulmonary veins going to the body minus the oxygen left in the pulmonary arteries coming back from the body must equal how much oxygen the body has used. Secondly, that the cardiac output for the right and left ventricles are the same. Using the Fick principle, cardiac output can be calculated by dividing the oxygen consumption of the body by the difference in oxygen content of the pulmonary veins and pulmonary arteries.
The main job of the heart is to pump oxygenated blood with nutrients through the arteries to the body's tissues, and then receive back deoxygenated blood full of waste products through the veins. Now let's zoom into the left ventricle. There's a moment when the left ventricle is fully relaxed, and it occurs at the end of filling, or diastole, also called the end diastolic point. And the volume of blood within the left ventricle is called the end diastolic volume, and it's about 120 milliliters. Then, the left ventricle contracts, forcing blood through the aorta and into the whole arterial system. After that is another moment when the left ventricle is fully contracted. This occurs at the end of contraction, or systole, also called the end systolic point, and the volume of blood within the left ventricle is called the end systolic volume, and it's about 50 milliliters. So, end diastolic volume minus end systolic volume gives us the stroke volume, which is the volume of blood that the left ventricle ejects with every heartbeat or stroke. In this case, the stroke volume is 120 minus 50, which equals 70 milliliters. Stroke volume is a useful measurement, but it can vary based on the size of a person. For example, a stroke volume of 50 milliliters might be absolutely fine for a small person with a small heart volume, but may be low for a large person with a bigger heart volume. So another helpful measurement is the ejection fraction, which is the stroke volume divided by the end diastolic volume. In a normal individual, that's 70 divided by 120, or about 58%, but it can fluctuate between 50 and 65% and still be considered normal. In other words, at least half of the blood volume in the left ventricle should get pumped out during each heartbeat. In hearts that have a low contractility, or a low force of contraction, the ejection fraction can fall below 50%. Every minute, though, our heart beats many times. The exact number of beats per minute is known as the heart rate, and if we multiply the stroke volume times the heart rate, we'll get the cardiac output, which is the total volume of blood that the left ventricle ejects in 1 minute. Using the stroke volume of 70 milliliters a beat and a resting heart rate of 70 beats a minute, cardiac output is 4,900 milliliters a minute, or 4.9 liters per minute. Now remember that a normal adult body contains approximately 5 liters of blood. So this means that every last drop of blood travels through the left ventricle at least once every minute. Of course, the heart can adjust its heart rate and the stroke volume based on whether you're sleeping or exercising. In fact, trained athletes can have a cardiac output that reaches up to 35 liters per minute. The cardiac output flows through the arteries and is distributed to the various organs and tissues to meet their oxygen and nutrient demands. Of all the organs, the liver receives the largest amount of blood flow. The kidneys also get a lot of blood flow, but less than the liver. However, when correcting for the mass of these tissues, the kidney gets much more blood per gram of tissue than any other organ, and this is called tissue perfusion. So, blood flow refers to the total amount of blood volume going someplace like an organ over time, and perfusion refers to the total amount of blood volume going to 1 gram of tissue over time. Alright, so as a quick recap, stroke volume is the volume of blood that's pumped by the left ventricle in a single heartbeat. The ejection fraction is the percentage of blood that's pumped out of the left ventricle with each heartbeat, and this can serve as a measure of the heart's contractility. And finally, cardiac output is the volume of blood pumped out of the heart in 1 minute.